Morning, everybody. I was asked to talk about some interesting cases that were challenging both in the positive and negative direction, and these are both off-label applications of the MR-guided focus ultrasound technology. I'll be presenting on behalf also of Dr. Napoli, who's not here. These are his cases, actually, for osteoid-osteoma. The take-home message here is that we've learned, sometimes just through experience, what kind of lesions we can reach and what we can't reach within the bone. So this is an intramedullary osteoid-osteoma that's circled there within the femur, and you can see that the lesion is beneath a layer of intact cortical bone, very dense cortical bone. This was targeted, and in that yellow cloud is the area where the dose appeared on the thermometry images. And unfortunately, in this case, you can see preoperatively these perfusion images, the nidus, the tumor itself, there's perfusion around it. And unfortunately, afterwards, you can see that the dark zone there does not include the nidus. In other words, the nidus remains perfused and the patient's symptoms persisted in this case. So penetrating intact cortical bone doesn't work. But it turns out that sometimes these tumors, these osteoid-osteomas, generate a reactive bone. And even though it appears nearly as dense as cortical bone on CT, it turns out actually that this reactive bone is penetratable with the beam. And so this is actually a cortically based osteoid-osteoma nidus, and this was targeted as well. Again, it seemed like the dose built up on the edge of the bone, even though it was reactive. You can see here preoperatively, again, the perfusion, showing the perfusion of the nidus, as well as inflammation. Afterwards, however, you can see that the non-perfused volume encompasses the reactive bone and the nidus itself. So just keep in mind that when you're trying to target these types of tumors, don't be daunted by this thick reactive bone. You can sometimes penetrate it, even though it looks very thick and dense. This was an example of a challenging case. This is a desmoid tumor in the rectus abdominis muscle that I've circled there. You can see the colon immediately behind it with stool. This is the second time I brought this patient in to treat. The first time the bowel was not immediately behind it. The second time it was. These tumors are very heterogeneous. Sometimes they absorb the beam very well, and very little of the intensity seems to penetrate beyond the tumor. In this case, it did not heat very well. These are just zoomed-in images showing how close the bowel is to the tumor in the far field. So the bowel is just deep to the tumor in the far field there. And the other challenge, of course, is that with air in the bowel, the thermometry is often unreliable. And so you don't know whether to trust it or not. You'll often see what looks like phase change, but it's just due to the air. In this case, again, you can see how close it was. In this case, I could see that thermometry, and for whatever reason, I was more suspicious, perhaps just because of the imaging. And so after 3 sonications in this area, I stopped and took these T2-weighted images. On the left there and on the right, the T1 pre-contrast images. And you can see the edema that's built up in the bowel wall. So I terminated this case because of what I was seeing in the bowel. There were no long-term sequelae at all. The patient was asymptomatic and mostly just gave me anxiety, but everything went well. Although she had to go on to get treated with, I think in this case, cryoablation rather than focus ultrasound. We didn't have a good way of moving the bowel out of the way in her case. This is another case that turned out to be a very positive result. This was a man who was shorter than me and much heavier than me. And he also had a desmoid tumor in his thigh and in his calf region. And as a result of the desmoid, his leg was in a kind of a fixed contracture. He wasn't able to fully extend and flex the leg. And so positioning him was an effort because of his size and because of the limited range of motion that he had. What we've done here is we've placed him on his side, and unfortunately with him in that position, what you're looking at is his calf from a lateral position there. And the tumor there is as far away from the transducer as it could possibly be. We had to use a thick gel pad. We've done a lot of stuff there to get him in the position. And the focal depth at which you're supposed to be able to use the exoblate system is about 14 centimeters from the mylar. In this case, we were closer to about 16, 18, 20 centimeters away from the target. However, what we've seen from experience within these tumors is that they have this very heterogeneous pattern of T2 signal intensity. Some of these tumors are very dark on T2, some are very bright. And in normal cases, what we see is that the same energy that within the bright region might result in adequate or even inadequate heating, within the dark regions will cavitate. And because there was so much of this dark tissue in the far field, we decided we would try it. sometimes we can use this tissue to our advantage and get very good heating in the tumor, even without directly targeting it. And as you can see, that's exactly what happened. So even though we saw very poor thermometry, very little predicted dose within this tumor, but you can see on the right image there, the non-perfused volume immediately after the treatment shows that the bulk of this area was actually ablated, even in the absence of seeing the thermal dose pile up within it. So you can use that heterogeneous tissue to your advantage as well. Thanks very much.